Presenting Mr. Prasenjit Das, a 53-year-old male businessman who's managing a courier service from Assam, who had presented to us with complaints of low back pain since the past 1.5 years and lower limb weakness since the past 1 year. History of presenting illness.
So just 1 second. So low back pain and lower limb weakness.
Yes, sir.
So I'm happy that you didn't say bilateral lower limb or things like paralysis and all, because it's supposed to be a complaint, supposed to be as in general term as possible, whatever the patient complains. Okay. And here you can add one thing. If it is there, it's like a progressive or it's a static pain or weakness. If it is there, if it is clinically relevant, that you think you must have thought. So that will give a long short in the list of differential diagnosis, right? Other thing is that low back pain is there since last 1.5 months.
Yes.
And lower limb weakness started last 1 year. So one thing that you have to be clear that are both part of the same pathology or both are different. So you think that the lower back pain is the same cause and that progressed into bilateral lower limb weakness, or both are something different. So if they are different, then you should not, you have to really separate them out in your history of presenting complaints. So the idea of entire history, examination, everything is to get a diagnosis. And diagnosis, whenever we think of, especially in neurology, but in entire general medicine, is first is the physiological diagnosis. That will just say, okay, both hemiparesis or paraparesis or something like that. And then we come to localization. So as soon as you say pain and weakness, I'm thinking of certain localization, right? And then of course the etiological comes last. What is the cause of that? So as soon as you've said pain and lower limb weakness, where all can pain in the back and lower limb weakness, what all areas do you know that can cause this kind of presentation?
So pain followed by weakness first points to a compressive pathology.
Yeah, right. So that's where. So first you have to think of anatomical localization. So where is the lesion?
So it can be start at the level of the root.
Right. Okay. So one is the root. Okay. Anything else?
Plexus and.
Okay, plexus becomes less likely, but it's okay. We'll keep it as one of the differentials. And something more important. The spinal cord itself. Okay. And finally, we have to think of multiple pathologies like a vertebral body pathology, which is impinging and causing lower limb weakness as well. Okay, so this is how you think of localization. So okay, somewhere in the cord, in the back, and then the nerves that are coming out of the cord. So that's already I'm thinking. So as soon as you gave me a physiological problem, I'm thinking of a localization, and then we'll jump to etiology later. So don't jump to etiology in the beginning itself. Try to localize where is the problem, and then we come to what is the problem. Okay. Okay.
So coming to the history of presenting illness, he was apparently well till April of 2020, 1.5 years ago, when he started having low back pain, which was mild dull pain with no radiation to the lower limbs, which is intermittent, requiring analgesics once in a week or two, more in the morning after getting up from sleep, which lasted for about an hour, and improvement over the day with activity. The pain is also present at rest and sometimes at night. There is no band-like sensation over the abdomen. The pain is not disturbing his activities of daily living, as he is able to do his normal activities like skipping and play sports like badminton almost daily. And there was no other joint involvement, no altered bowel habits, no eye symptoms. There was no history of any loin pain, and there was no history of preceding trauma or fever to the back pain.
Right. So when you say pain, given all your characteristics that you've given us, so what all areas can cause low back pain?
So it can be bone.
Okay, very good. So the vertebral bones, the vertebrae. Okay.
Then it can be spinal cord.
Okay, spinal cord is less likely because spinal cord problems, myelitis per se, if you say, it will generally cause the entire pain is a very diffuse pain, in a funicular pain. It's a very burning kind of pain if lateral column is involved. So just back pain being spinal cord is less likely. Root is more likely, of course.
Then can be muscular pain.
So when you say bone, just finish off.
It
It
can
could
be
be a
either
vertebral body
vertebra or a side joint.
or the various joints, not just the sacral leg joint, the intervertebral disc problems, the facet joints, the sacral leg joints. So bone means the body as well as all the joints, the ligaments, the attachments that are there. All those are can be pain sensitive areas and can give rise to low back pain. And those are the most common causes of pain when we say mechanical back pain due to certain abnormal postures and all. So in general practice that we see most commonly. So spondylosis kind of, when we say general term, these are all the areas where pain can arise from. Then if you want, you can add ligaments attached and muscles also over here itself. So any pull, strain, injury, those can also give rise to pain. Then roots is the other thing you said. What else?
Then
so you said something loin to groin and all. So what were you trying to implicate there?
the plexus, if it's involved the plexus.
Okay, more commonly.
Then other causes of back pain, even internal organ can cause.
Yeah, so you have to make sure. Yeah, so all pain need not be neurological. So right at this time you don't have any weakness, so you just have pain. So you have to make sure that there is no other intra-abdominal causes, retroperitoneal causes of pain. Renal calculus can cause loin to groin kind of pain. Ureteric calculus. All these things also you have to consider at this point of time. And that, of course, will that's where your history of the pain characterization itself, when it is worse, when it is more, is it a colic type of pain, or all those things will come into picture. So you say it's more in the morning. What does that imply?
That is more characteristic of inflammatory low back pain.
Yes. Okay. So inflammatory means what? Where's the inflammation?
At the joint, like
so inflammatory arthritis. When we say inflammatory pain, we're talking about inflammatory arthritis. So those generally cause pain which is early in the morning. So whenever you say pain early in the morning, just finish up one more history. What is that?
Early morning stiffness.
Stiffness, yeah. So is there any stiffness associated with pain? So if you don't have stiffness, then that's a very characteristic history that you get in inflammatory arthropathies. Okay. Right. So is the pain worse at night? You were saying something. The pain?
No, sir. It's not worse at night. He said it's present at night also, but
Okay.
it's worse in the morning.
Okay.
After getting up from sleep.
Right. And the pain reduces on walking.
On
that's
activity.
What you're saying. So where do you get pain worsens on activity?
If it's a radicular, if it's a compressive.
Yeah, it's a compressive pain generally worsens with activity. So the term that you use is the neurologic claudication. So you have a certain distance after which you will start getting pain, and pain gets better on relaxation. Okay. So when you after entire characterization, what do you think where the pain is? Where all the pain can arise?
Most likely bone
Okay.
inflammatory.
So it's more likely a bone pain because it's a central. More not in one of the sides. And because it's more in the morning and will get released with rest, you would like to keep an inflammatory arthropathy as more likely cause. Okay.
That is in April, and 3 months after the onset of back pain, he started developing right side lower limb pain, which he described as a crampy muscular pain in the region of the calf and the thigh. More after walking for a long distance, around 200 meters, and relief after 2 to 3 minutes of rest. But there was no worsening with bending forward. Subsequently, he noticed thinning of muscles of the right lower limb, more over the thigh than the leg. This was followed by gait disturbance, as he was noted to have dragging of the right foot while walking by the relatives, with slippage of footwear while walking. There was no feeling of tightness or heaviness noticed over the lower limbs. There was no numbness or tingling sensation. He was able to feel his clothes and cold water when he takes bath. And 2 months after this right lower limb complaint started, he started noticing the similar complaints on the left lower limb.
So one lower limb weakness started around 3 months later. Right? Now, there is important thing that there is associated pain as well. It's not just weakness; there is pain also. So now, limb pain. How do you want to localize in the right limb pain?
So most commonly be either a neurogenic claudication or a vascular claudication.
Okay, very good.
So based on his history, sir, this is not typical of neurogenic claudication. It's it's a crampy muscular pain which worsen with which improve with rest. So historically, it sounds more like vascular claudication.
Okay, sure. So vascular claudication, whenever you say, you should also bring in. So any color changes were there, any paresthesias were there, any change or any features of Raynaud's phenomenon. So these are all which are associated with, not necessarily, but can be associated with vascular pain. So if those you bring in and those are clearly present, then this thing becomes very clear. Okay. So calf and thigh pain, you think it's arising from a muscle and not in the root, is it?
Not in the.
Okay. So, but then after some time, you again started getting weakness also. So how do you localize the weakness on one side when it was there? Or if you saw the patient at that time?
Yes. It was based on the history, so it was distal to proximal.
Right. So weakness, the broad localization just begins as simple as is it a lower motor neuron type of weakness or is it an upper motor neuron type of weakness? So on history, when can you call it a upper motor neuron type of weakness and when can you call it a lower motor neuron type?
Upper motor type of weakness that they will have
on history.
Feeling of the limb being tight, and even they can even UMN can have difficult slippage of footwear while walking, sir.
Right.
Then upper limb.
So upper motor neuron findings on history will be limb feels tight. Then a very good history that generally is present in a lot of patients is, especially when there's a dragging, is
more on uneven on
more on uneven. Okay, and tripping over small objects. So they find it very difficult to cross small heights which are there on the way. So suppose a shoe is kept on the way, they will not be able to jump over it and keep walking. They invariably hit the shoe or hit an object or trip over and fall as well. What's the reason for that?
Because of the spasticity.
Yeah, so spasticity, the extensor tone is more. So dorsiflexion at angle is a little bit difficult, so that's why they hit an object. Right. So that's one very good history that you'll almost always get in a UMN type of lesion. Other things you said tightness, and third thing will be any history of flexor spasm. So limbs going into a tight spasm by their own. Some patients they give history of clonus of the limb as well. So in certain position they'll say that the limb starts moving, and when they change the position, the movement stops. So that's a history which says of clonus. So that also suggests an upper motor. So whenever you say weakness, you should describe the scope of the weakness, whether it's proximal, intermediate, distal, difficulty in getting up, or slipping of chapel, or is there a twisting of the at knee, ankle. But that gives a scope of the weakness, where all the weaknesses. And the immediate plan on your history should be decide whether the UMN or element type of weakness. Now, based on the history that you have given, can you say whether it's a UMN or element type of weakness?
He doesn't have any history of adductor or any spasms, and
so I have told you what are the UMN history. So element history, what all you will get. So you said some features which are fitting into an element type of weakness.
He did not notice any twitching of muscles. That will be one history which.
Okay, so lower motor neuron starts from
the anterior horn.
Anterior horn cell. Okay, and then
plexus.
And then the root. Then it comes out. The root travels for a long time as cauda equina. Then it comes out from the vertebral body. Then multiple roots form to join together to form a plexus. Then the nerve comes out, and then we have a neuromuscular junction
and the muscle.
And the muscle. So this entire thing is the lower motor neuron complex, right? So the some history that you suggested, which says that this might be a lower motor neuron, will be one was.
If you notice any twitching of the muscles.
Okay, so if this twitching, you can clearly say that this is the element of weakness and which is from the anterior motor neuron. Anything else?
A patient will feel that his leg is like he will feel heaviness of his leg while walking.
Okay, more importantly, thinning. So wasting is a feature of element type of weakness. So twitching is one and wasting is one. And limb feels flail. Some patients might say that limb feels flail. There are certain specific findings in muscle and neuromuscular junction. In neuromuscular, there will be a history of diurnal variation. And muscle, of course, there's a lot of other history that there may be pigmenturia, there may be muscle edema, there may be muscle weakness, which presents like in a muscle angina. Those things also may be there. So, so you have a patient who presented with calf pain, thigh pain, and then goes on to develop muscle weakness with thinning. So that's an important history. So there's clearly patient has himself noticed thinning. So this suggests that this will be more likely an element kind of weakness than a human kind of weakness. Anything else that you want to add over here? You want to say the dragging or about anything about dragging? Is there is the dragging like a flail kind of dragging, or he cannot move his leg up? That's why he move his toe up or foot up, and that's why he's dragging.
Yeah, this is mainly he did not notice unable to flex the ankle as such. He was just noted to have dragging of the right foot while walking by his relative.
Okay, sure. So we'll leave it at that. So after 3 months again, he progressed on to develop weakness of the other side as well.
Yes.
Okay. So what happened? Can you say?
With a similar progression, sir, with crampy pain and thinning of the muscle was the predominant symptom which he noticed. After that was the weakness. So which again started with difficulty gripping footwear and followed by bucking of his while walking. This is and by the end of this 2 months, then this weakness progressively worsened, and he eventually required a walker to walk. Since that time, he was only ambulating at home. He also developed difficulty getting up from sitting to work, and he required support for the same. And from that time, he was partially dependent for his ADL, and there was slow progression. At that time, the progression of weakness is static, and throughout this whole time, he did not have any complaint of tingling sensation, numbness, no history of fall while washing face or worsening of gait in the dark.
Right. So one very good history that will be there is buckling. So buckling gives a good element feature. It need not always be, but mostly it is seen in low motor neuron type of weakness. You can have sometimes in upper motor as well. So upper motor, usually you don't get buckling at knee because the quadriceps tone is very high, but sometimes if it is very severe weakness, you can still get. Now when you get buckling at ankle, then followed by buckling at knee, and then followed by buckling at the difficulty in getting up. So this suggests an ascending kind of pattern rather than a descending kind of pattern. So this ascending pattern was there in both legs or only on one side?
In both legs, sir.
So first he starts in the lower limb on the left side. He starts with difficult distal weakness, then buckling at knee, and then proximal weakness, and then the other side, right side as well, where there is slipping of footwear, buckling at ankle, buckling at knee, and then difficulty in getting up. So what we can say is that it's a predominantly motor weakness without much of sensory involvement. Anything else that you want to add at this time, which has a impact on localization? So we said that weakness can arise out of LMN or UMN, and LMN starts from, always remember, it starts in anterior motor neuron, then root, then plexus, then nerve. So if you are thinking of pure LMN disease, anything else you want to add over here that will help in? So one is sensory that you said, there are no sensory features at all. Other than pain, there is no sensory features at all. Anything else which is there that you want to add?
Any autonomic?
Yeah, very good. So autonomic in the form of?
Any history of, he did not have any history of postural giddiness, no excessive sweating or any history of sexual dysfunction.
More importantly, you want to add here is one is sexual dysfunction. Okay, then in the form of erectile or early ejaculation. Both are important. Or bladder.
Yeah.
So how will you ask history of bladder here? So bladder is a little bit difficult over here. So how will you ask history of bladder involvement?
Retention of urine, not able to pass.
So often if it is if the sensor is completely normal, then the patient may complain that he feels that his bladder is full but is not able to pass. But often they'll just it will be overflow bladder kind of history. So patient might see the abdomen getting distended but is not able to pass, or he may have to, or in milder forms when he has to sensation of incomplete passage of urine, he has to press the abdomen or go past urine, but he still feels that he's passed very little for whatever your sensation was there. So if there is any, let's say if the patient has any urgency and urgent continence, then what do you think of?
More of a and bladder.
Yeah, so it suggests that this is the upper motor neuron level bladder, and the lesion is above the S1 level in the cord or below the fontaine level. Sure. So he doesn't have any bladder history in the form of retention, overflow, urgency, urgent continence, nothing. Sure. And there is no erectile dysfunction as well. And his sweating is not. So whenever you ask history of sweating, you will not generally not get history of decreased sweating. You will get history of compensatory hyperhidrosis. So somebody who has a autonomic dysfunction below the chest, you will not get history of decreased sweating over below the chest. Rather, the patient will generally complain that they have increased sweating. And then when you ask whether the chapels are wet and all those things, then they'll say, oh, these are not there. Then that's how you discover their sweating history. So sweating has a generally poor localization in terms of history, more in terms of examination. But hypohidrosis has a better localization. Okay.
From October 2020, he was dependent on walker to walk. And this has progressed slowly over the past 8 months, and since 2 months back he was from that time he was not able to use his lower limbs and required wheelchair support and need to be carried to the wheelchair or to the bed. But he was still able to turn from side to side. He was able to sit straight with with his leg crossed, and there was no difficulty lifting his head while lying down. There was no history of upper limb weakness, as he was able to mix his food, no dropping of objects. He's able to comb his hair and brush his teeth and able to change his shirt by himself. There was no tightness of the upper limbs which was noted, and he did not notice any twitching of the muscles in the upper limb also.
Okay.
So there was no history of bowel or bladder incontinence. There was no history of orthopnea. There was no history of diplopia, drooping of eyelid, facial deviation, difficulty with speech, swallowing difficulty, or regurgitation of food. No history of excessive sweating, postural giddiness. No history of, and there was no history of IV drug abuse or high risk behavior. No CVD features like dry eyes, dry mouth, Raynaud's phenomenon. No history of intake of any alternative medication.
Okay.
Past medical history, he did not have any non-medical comorbidities. Family history, mother has small joint arthritis, which was managed conservatively, and father is a non-diabetes and hypertension. No history of similar illness in the family, and no history of TB in the family. Personal history, sir, he has unquantifiable weight loss, appetite is fair, sleep pattern is normal, with no addiction. Can I summarize my history?
Yes.
53-year-old gentleman with non-comorbidities, with inflammatory type of, presented with an inflammatory type of back pain, followed by insidious onset, gradually progressive lower limb weakness over the past 1 year, which is asymmetric in onset, distal to proximal progression with significant wasting, with no sensory or bowel and bladder involvement.
So it's a pure motor syndrome. That's what we're trying to say. Okay. So again, coming to the same thing, your syndrome is that of a pure motor type of weakness in both lower limbs. Now here you have to make a call whether you can discuss it both ways. You can combine low back pain and the motor weakness, or you can discuss both as a separate entities as well. Both are okay. So weakness, how do you want to, where do you want to localize now?
So after the history, the most probable localization is either to the peripheral nerve or root or possible anterior motor.
So it will always be difficult to localize based on pure history. So whenever somebody says you have to keep a broad mind. So let me ask you: let's start from anterior motor neuron, right? So is the anterior horn cell involvement likely here? So what are the features in favor? What are the features against anterior horn cell?
So features and favoring anterior horn cell will be like it's an element type of weakness.
Very good. Okay.
Yeah, and yeah.
So whenever you have let's say I give you a question. So can a cord involvement, let's say a cervical cord involvement, or the highest level is cervical cord, can you get a lower motor neuron type of weakness in the lower limb?
If it is a localized lesion, no, so it will be
very good. Lesion. So you should not get. So in the initial phase, it may get when there's a spinal shock, but eventually you will get human findings. So if you have a highest level at a cervical cord, let's say you have upper limb weakness or sensory level, but you still have a lower limb element type of weakness, the only place where you can get such a thing is that there's a destructive level of destruction of all the anterior horn cells. So at each level, so you can get that either in this very bad lesion of the entire cord. So classically, this used to be seen in the Devic syndrome, the old, which we don't see as frequently as now because of better treatment. And the other situation where you'll get is a specific anterior horn cell specific disease, that is motor neuron disease. So that's where the localization becomes very important. So if now even coming to your patient, the patient has a lesion weakness which is involving right from S1 or L5 at least to L1 at least. So this is decently a big lesion if you say cord. So if you say just cord, the lesion has to go through L1, L2, L3, L4. Now, if it goes through all these places and doesn't involve any sensory, any motor, it's difficult. So corticospinal tract only on this side and then corticospinal tract only on this side, without any other involvement, is difficult. So a lesion will be difficult unless it's a system-specific disease, like a anterior horn cell disease. Then we can explain it. Or any other case. There are some other certain diseases which can cause only corticospinal tract involvement. That will come to that later. So that is one possibility. So if you say localize it to cord, it will be only anterior horn cell. It will be a little difficult to explain unless it's a system-specific disease. So did you get my point?
Yes, sir.
Okay. So like a motor neuron disease when you talk about, or certain tractopathies and all, which we'll discuss later. Okay. And so coming out of anterior horn cell, do you think radiculopathy is possible?
Yeah, especially sir because of the history of preceding back pain.
Yeah, very good. So if you want to bring in back pain as well as the calf and thigh pain, radiculopathy is possible. Okay.
Yeah. So the points against radicular pain will be distal predominant, as in distal to proximal progression.
Right. So typically we get radiculopathy. The pain is typically in a radiculopathy. The pain is proximal. That's what we say. The reason for that is not in general radiculopathy, because the commonest root which they're involved in a disease is the L5 root. So whichever root is involved, you will get pain over there. So in a radiculopathy also you can get some distal pain as well. Okay, so root is possible, and specifically the pain that the patient had was thigh and calf pain. That can be there in a root disease as well. So and wasting which was there. Okay, sure. So now you have to keep in mind. So in the examination, you have to show that the muscles that are involved are root specific and not nerve specific. If that is so, then radiculopathy will become a more likely diagnosis. Okay, is plexus possible?
Plexus is also possible, sir. There is no history of loin pain.
Yes.
But and fact that it is a pure motor goes against it.
Yes, very good. So plexus generally will have some amount of sensory involvement, definitely. Pure motor is very less likely. It's possible, but it becomes very less likely. So plexus classically you get retroperitoneal disease or any it can be any multiple differentials from malignancies to neurological disorders. It's a big differential. What about nerve? Is it possible?
Yeah, peripheral nerve is possible, sir. The point forward towards this will be the length-dependent pattern of symptoms, and yeah,
so length dependent need not be nerve. So nerve can be length dependent as well as length independent. So when we say independent, it is usually a demyelinating or a involving myelin sheath. When we say length dependent, it's usually an axonal involvement, and so nerve can be both. So it's a motor nerve specific. It is still possible, especially because there is presence of wasting. Pain will not be explained in case of nerve. Is a muscle possible?
Muscle is less likely, sir, because it is unilateral to start with. And it is again distal to proximal.
So any features which are in favor of a muscle disease?
Is the cramp?
Yes, cramp is very good. So cramp as well as so first thing is that you can say this element type of weakness. If there was a muscle cramping followed by weakness, which can be there in certain muscle diseases. So muscle is possible. However, there is wasting, which makes muscle less likely, which is generally not seen. Okay. Sure. So distal to proximal generally rules out a muscle. Muscle generally starts proximal and goes distal, but that's not a definite thing. If you have any certain muscle selectivity, so certain group of muscles which are more involved, then we can say muscle is less likely. Because some diseases they involve muscle more, some certain groups of muscle more than the other. Okay. So, examination.
So one examination is a thinly built gentleman sitting up with folded legs on the bed, comfortable and in no distress. His vital signs were stable with a heart rate of 72 per minute, BP of 152/80. Postural blood pressure could not be assessed. The respiratory rate was 20 per minute with no paradoxical breathing and not using any accessory muscle of respiration. On general examination, there was no pallor, ictus, clubbing, cyanosis, pedal edema, or lymphadenopathy. He did not have any neurocutaneous markers, no peripheral markers of internal malignancy, or no peripheral markers of tuberculosis. And on CNS examination, he's alert and cooperative, conscious, oriented. Language and speech was normal. MMSD was 30/30. Cranial nerve examination, the first cranial nerve was normal. Second cranial nerve, bilateral pupillary pupils were equal and reacting to light. He has a mature cataract on the left side. And
so if you have any cranial nerve findings which are significant, you can say
cranial nerve examination was normal.
So specifically you have to look for this if there's any
no subtle UMNs, and jaw jerk was normal, and there were no fasciculation, over the time.
Okay, and no jaw weakness as well. So nothing was no findings. Sure. Motor system examination.
Motor examination, sir. There was wasting bilateral lower limbs, right more than the left, sir. Upper limb bulk was normal and symmetric. Lower limb, sir, over the thigh, there was 33 centimeter on the right side, 36 on the left side, and over the leg, 23 centimeter on the right and 25 centimeter on the left leg.
So, was there a pattern of wasting? So, when I say that.
If asymmetric and proximal wasting more dominant, more predominant, and
very good. So that's a very important thing. So now you have to ask a question whether it's a root pattern. So certain muscles which so the quadriceps L2, L3, L4, if they are wasted, then we can say it's a root. So quadriceps and adductors are both together are L2, L3, L4. They're the same root but different nerves. So quadriceps provide femoral, whereas adductors are innervated by the obturator nerve. So it's different nerve but same root. So if both are involved, then we can say that this is a root pattern. Or if you have a dorsiflexion at ankle, that's a TA muscle, and adductor at hip, abduction at hip. So they both are different nerves, but supplied by the same root. That's the L5 root. So if you have a root pattern of weakness, it becomes very easy to say. Wasting, it becomes easy to say that this is a radiculopathy. So that's something which you have to look for carefully. So L1, L2 again, flexion at hip, flexors of hip if they are wasted, or the quadriceps muscles if they are wasted, that's L2, L3, L4. L5 specifically you have to look for is the TA muscle and the gluteus medius, gluteus maximus also maybe. For this you have to undress the patient and see carefully. S1 you have to specifically look at the calf gastroc muscle if that is wasted. Okay. And of course, the other L5S1, L4, L5S1 is also the biceps femoris and the hamstring muscles if they are wasted. So if one group is wasted more than the other, then you can say that this is a radiculopathy. So one very common radiculopathy is L5 radiculopathy, where you get a foot drop presentation, patient presents with wasting, patient presents with some pain, and the patient has dragging of feet and thinning of limbs as well. And the patient has, if you find on examination that the TA is weak and the gastroc is normal, adduction is weak, but adduction is normal, but abduction is weak, then you can say this is L5 radiculopathy. It becomes very simple. So whenever you look at wasting, in generalized wasting, plus whether it's a root pattern, is it a nerve pattern? Okay. So nerve, again, you have important nerves as femoral nerve, you have the obturator nerve, and you have the sciatic nerve. Sciatic nerve again has a tibial component, which is the hamstring and the gastroc muscles, and you have the peroneal component, which is the peroneal and the TA muscle. So this is a broad group in lower limb of a nerve pattern versus a root pattern. Okay. So any pattern of wasting was there, or was it a generalized wasting?
Generalized wasting.
Okay. So again, generalized wasting, whether it's a generalized disease, it's a neuropathy, which is generalized, it's a multiple roots are involved, or anterior horn cell becomes very likely in case of a generalized wasting which is there. Okay.
So there was decreased on bilateral lower limbs and fasciculation was present.
Fasciculation was where that also is mentioned.
Yes. Noted over the lateral aspect of the thighs.
Okay. Sure. So lateral aspect of the thigh is again the vastus lateralis muscle, which is supplied by the femoral nerve, which is L2, L3, L4. Mostly L4 innervation in the lateral aspect of the thigh. So if you find a similar thing on the adductor muscle also, then you can say, okay, this is a root disease and not a nerve disease. Okay.
So examination of upper limb was normal, and in the lower limb, sir, there is a distal predominant weakness. At the hip, flexion and extension was 3/5 bilaterally. Adduction and abduction was 2/5, and knee flexion and extension was 2/5 bilaterally, and ankle dorsiflexion and plantar flexion was 1/5 bilaterally.
So both dorsiflexion and plantar flexion are weak. Knee flexion and extension both are weak.
Both are weak, yes, sir.
So flexion, I hope you examine in prone position. Prone. Yeah, very good. Otherwise, it's very difficult to say. Okay. Sure. And hip also, both flexion and. So what you have to look here is there a difference? So if the flexion is out of proportion of adduction, then it's a different disease. If the flexion is more weaker than extension. So in most lumbosacral plexopathy, you'll find that flexion at hip and extension at knee, which is the most weak. Other muscles are relatively spared. Okay. So we can clearly say that this is not the case here. Okay.
Sensory examination was normal, sir, for pain touch, posterior sensation, and perineal sensation was normal. Reflexes, upper limb reflexes, biceps, triceps, supinator were 2+. There was absent reflexes in bilateral knee and ankle. Plantar reflexes was mute bilaterally. Hoffman sign was negative. Signs of cerebral dysfunction was not there. Meningeal signs, no spinal tenderness, and other systemic examination was normal.
Here, one thing is that you can add is that how was the tone of the paraspinal muscle? It's a little difficult to see, but you have to palpate the muscles and see if they're flaccid or something like that. Then you can get the level higher, basically.
Summarizing history and examination, 53-year-old gentleman with no known comorbidities were presented with inflammatory type of back pain followed by insidious onset, gradually progressive lower limb weakness, asymmetric in onset, distal to proximal progression, with significant wasting noted, with no sensorial bowel involvement. And on examination, found to have a pure motor element type of weakness with no sensory involvement, and involving only the upper limbs with no only the lower limbs with no upper limb or bulbar involvement.
Right. So when you summarize, just say the positive things first and the relevant negative things if you want. So bilateral lower limb element type of weakness, which is inferior onset, gradually progressive bilateral lower limb weakness. without any sensory, autonomic, or upper limb cranial nerve involvement. Okay, so this is your syndrome. Now, where would you localize it?
So after history examination, most probable localization is most likely it's a radicular neuropathy.
Right. So again, uh, you what you have to do here is initially just say that it is a lower motor neuron diversion. So your syndrome and then lower motor neuron cannot go wrong at all, right? Now, so why do you want to say radicular neuropathy? Why is it not just a neuropathy?
Because of the asymmetric onset with
Okay.
the which is having a lot of
So you can say because of the pain. So
yeah,
the calf pain which preceded, that's why I want to bring in roots also. And why do you want to say neuropathy?
Because of the
Why is it not just
because of the distal to proximal on progression of weakness.
So that I explained. So distal can be there in root as well. So if it is a L5S1 root, we can have dorsiflexion and plantar flexion. So there is no root pattern that you found. That's one way you can see that, because there was no specific root pattern of involvement. That's why I would like to keep roots less likely. Okay. Why not anti-horn cell?
Anterior horn cell is possible. The only thing against it is there's no UMN features.
So anterior horn cell plane need not have UMN features. So it's when you have a UMN features means you have a pyramidal corticospinal tract involvement. So just anterior horn cell at let's say L3, L4, L5, all those are damaged.
Sir, again, the distal to
proximal is also possible. That's not unlikely. That's also a possibility. Why you cannot rule it out completely.
Yes, sir.
So it can be anterior disease, it can be a root disease, it can be a root, it can be a peripheral nerve as well. Nerve again, it's just pure motor nerve. It's not a mixed nerve, so it's not a that neuropathy. What etiological differences would you like to keep? So in the background of low back pain and history of weight loss as well, am I right?
And quantifiable weight loss. Yes,
and quantifiable weight loss. So if you want to keep weight loss significant, differentials will change. Otherwise, right. So what do you want to keep your differentials as?
Sir, if it's so from
now when we say differentials, each localization will have differential disease.
Yes.
So that's good. So the differentials will vary from different locally. So suppose if you say that it's an anterior horn cell disease, then what differentials will you consider?
Then it has to be a pure element type of motor neuron disease.
Pure element type variant of motor neuron disease. Very good. Okay. This is possible, although we have considered this less likely, but it's one possibility. Very good.
Or paraneoplastic process can cause.
Very good. So paraneoplastic can cause a tract specific. When we were talking about system specific, paraneoplastic diseases are known to cause only corticospinal tract, only spinal thalamic tract. So paraneoplastic pathology is possible. Okay, very good. Then next, going on to root and nerve.
Then with the history of back pain again, sir, I would like to consider, like with his age, 53-year-old degenerative spine disease.
Right. So degenerative disc disease, which, when you are saying, you are implying that there is a disc which is compressing on the roots, right? As the roots are traversing through the chorda equina, right? So when the root comes out of the cord, it traverses the chorda equina and then comes out at each level. And below L1, the cord comes down, and below that, somewhere there's a disc which is compressing the root. Is that what you're saying?
Yes.
Right. So, yeah, that's a very common pathology. The only thing is that you have no sensory symptoms at all, no sensory findings at all. So it becomes a little difficult for multiple motor roots to be compressed across both limbs and having no symptoms at all. Again, the other thing is that, of course, it can be a diffuse radiculopathy, but this has to be a very high. So when you're saying that flexion at hip is also involved, that means L2, L3, L4, even L1 is involved, right? So it has to be a very high. So at that level, when you get, so degenerative problems generally come at L2, L3, L4. So it's a little bit higher. So that's why it becomes this disease causing all the symptoms become very less likely. So whenever you have flexion at hip and all, also involved. Cauda equina syndrome is another differential that, but then again, no sensory, no bladder, nothing is there, so that becomes less likely. So in general, Cauda equina syndrome causing root, everything becomes less likely over here. As the roots comes out, motor roots come out, they can get involved there because of a posterolateral disc. That's one possibility. But then again, both sides, it becomes less likely. If it is only one side, pure motor, it's still possible, but both sides becomes less likely. Anything else that you want to consider?
Like infectious diseases like TB with.
So one thing you have to consider that this is a very motor specific disease. So it cannot be one cut or one lesion that can extend. So it has to involve specific motor nerves, motor root, or the anterior horn cells. So as we talked about motor system disease like a motor neuron disease or a paraneoplastic. So any other disease, nerve diseases that cause motor nerve or root involvement. When you talk about root. So any inflammatory disease that involves root,
and like sarcoidosis.
More commonly AIDP, CIDP. So they can involve motor roots per se. They can cause weakness, wasting, which can be in a proximal or a distal pattern. And this they can involve sensory as well as motor, but often they can have only pure motor.
CIDP.
So motor CIDP, although it's less likely, very less common, but that's one possibility. If it is an acute, then of course acute motor neuronopathy like a CIDP, GBS kind of variant will be more possible. Okay. Any other disease that you know which involves motor nerves only?
After that, in neuromuscular junction and muscular diseases are less likely because.
So muscle diseases wasting, which are the muscle diseases where you have wasting? So answer is all muscle diseases have wasting eventually. But early wasting can be seen in. So thyroid diseases, thyroid myopathies can have wasting as well as they can have fasciculation also. So that's one. And paraneoplastic myopathies also can have wasting and fasciculation. So these two differentials that you have to keep in mind. Okay. Right. So you want to wrap up finally. What do you want to do for this patient?
So because we are thinking of element type of lower limb weakness, I would first like to proceed with the MRI spine.
Okay, so when you ask for MRI spine, but so spine, all that you'll get is there any compressive lesion at the root, the cauda equina? Okay, so very good. So when you ask for the spine, your level will be at what?
Highest level is L1.
Yeah, very good. So that's where the localization becomes important. Okay. So suppose the MRI scan is completely normal. What else will you consider?
Next would be EMG and CV.
Okay. So EMG and CV again you consider it as an extension of your examination. So all that the EMG will say here now is that
external or demyelinating.
No, first whether there is a sensory or a motor. So sensory we expect that will be normal. There will be some amount of motor involvement. Now motor we can classify into whether it's a myopathic pattern or a neurogenic pattern, and then we can go ahead and say whether this neurogenic pattern is a root pattern, a nerve pattern, or an anterior horn cell type of pattern. Is there any active denervation happening, or is there a chronic denervation? So these things will help in a differential. Or if there is any feature of denervation in the normal size also, then you can have. Okay. Other one place where nerve conduction study will help is a differential of multifocal motor neuropathy with conduction block. It can also present with lower limb weakness with some amount of wasting. There can be some fasciculation. And the only way to diagnose is a nerve study. You can have a ganglioside antibody which may be positive. Okay. Okay. So other thing is if you want to evaluate the weight loss and the low back pain, what will you do? The inflammatory markers, imaging will help.
Okay.